Welcome everyone to today's webinar. I'm Aaliyah Pavala, reporter with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is my pleasure to introduce today's presenters. Dr. Lyle Berkowitz is Chief Medical Officer and Executive Vice President of Product for MDLIVE, as well as President of the MDLIVE Medical Group, one of the largest virtual primary care groups in the nation. Dr. Berkowitz is a primary care physician who previously spent over 2 decades helping lead healthcare IT and innovation at Northwestern Medicine in Chicago. Our second presenter, Dr. Cynthia Zelis, is Vice President of Ambulatory Operations and Telehealth Services at University Hospitals Cleveland, where she is responsible for the strategic design and collaborative oversight of the Ambulatory Network, composed of more than 50 ambulatory sites over 16 counties with a $585 million annual net revenue. Within the portfolio of telehealth, Dr. Zelis currently serves as the operational leader for the telehealth services, advancing digital healthcare through internally developed online scheduling platform and virtual care program development and implementation across the continuum of care, including direct to consumers, inpatient, and outpatient services. A practicing family physician, Dr. Zelis serves as an adjunct professor at Baldwin-Wallace University as part of their healthcare MBA program. Additionally, Dr. Zelis serves her Northeast Ohio community through board appointments and philanthropic leadership. Our third presenter, Dr. John Nosta, is a leader in the digital health movement with a background that is both eclectic and impressive. His resume contains some of the key words that drive innovation in today's complex world. They include Harvard, where he studied cardiovascular physiology, Ogilvy, the world's largest healthcare communications agency, where he was the Chief Creative Officer, Chief Strategic Officer, and Unit President, Forbes, where he writes extensively on digital health, Google, where he currently sits on the Health Advisory Board, Ambulatory University, where he serves as a faculty member and participant in the Exponential Medicine meeting. John is also the founder and president of Nosta Lab, a digital health think tank that looks at empowering innovation via strategic and creative thinking. I will now turn the floor over to John to begin today's presentation.
Thank you very much, Aaliyah, and hello, everybody. Dr. Zelis, Dr. Berkowitz. I think this is the most important hour in the health tech world today. We are going to address what I think are really, really key issues in the evolution and the utility of telemedicine. Now, I'm going to challenge you each to tell us a little bit about yourselves. I'll start with Dr. Zelis. And I want you to incorporate a little bit about how the heck you got into telemedicine. I know that as a practicing physician and with an MBA, I think it's an interesting opportunity. So a little bit of your background and make the connection for us about how you got involved and represent such an important position in telemedicine in the country today.
Thanks, John, and thanks MDLIVE and Becker for the opportunity here to talk. My journey as both a daughter of a family physician and a practicing primary care physician, I would say I've always been the person in many primary care aspects that we partner with our patients and our continuum of care teams, whether it be specialty services, hospitals, medical centers, post-acute, to really help our patients have the most comprehensive, highest quality, and most effective care. And in my personal transition from being a primary care 100% full-time with patients directly at bedside and in the office to now more of a physician leadership incorporated with the health system, that same partnership exists on the ability to be a greater partner and a greater voice for our patients and providers. And telemedicine continues that journey to provide a comprehensive, highest quality, most effective, and highest value. It also is aligned with being a little bit innovative and disruptive, knowing that at the end of the day, we have to take care of our patients effectively, efficiently, and with highest access. So I've been thrilled to be a part of University Hospital's journey, both in the complete care of a patient, but really looking on aspects of how we involve telehealth. For those who are not aware on this call, is one of our leading health systems. We celebrated over 150 years just 2 years ago, really serving more than 1.2 million patients. And the really key is essentially nearly 1 of 4 are part of an accountable care organization, which, as many of us know on the line, is as we transition from volume versus value-based healthcare. And telemedicine itself will be one of the key components that we need to do to practice and advance our healthcare of our patients to really receive that triple aim that the accountable care organizations have strived to: highest quality, lowest cost, provider engagement, and highest patient experience. So I'm excited to be a part of the journey, both locally, regionally, and nationally. So thanks, John.
My pleasure. That's a very powerful and informed background. I think if we could just dissect what you just said and break it down, we would have a wonderful dialogue. But Dr. Berkowitz, let's jump over to you, and you can tell us a little bit about your background and how you connected with both telemedicine and MDLIVE.
Yeah. So similar to Dr. Zelis, I'm a primary care physician. My father was a primary care physician, and it's certainly in my blood that I believe primary care is so important to the health of the nation, and everybody deserves great primary care. In my role at Northwestern Medicine, based out of Chicago, I helped at both the primary care group level and eventually the system level bring in information technologies, EMRs, etc., and innovative thinking and technologies. So quite honestly, have been doing telehealth for past 20 years, one form or another. Was one of the early doctors emailing, communicating, and recognizing the importance of that. And with that said, we've been doing telehealth for 100 years in medicine with telephones, etc. So number one, I think primary care is super important for everybody. But number two, recognize that quality means more than your A1C metrics. Quality, in many cases, is access to care. And we know in our nation that 50% of people don't have easy access to primary care. Even those who do often don't get everything that they need to get because our doctors are overburdened with what Don Berwick described as the tyranny of the office visit. Everything has to be done in the office. Everything has the same 15 or 20-minute visit, and it just doesn't scale well. So the third part is, how do we scale? And this is where automation and virtualization become important. I was trying to do a variety of things at Northwestern to help with this. But when folks at MDLIVE came to me at the end of last year and said, hey, how would you like to take this in a fast-moving company that's really looking to disrupt healthcare by bringing in not virtualization, but also starting to think about automation as well. And so virtualizing telehealth allows us to virtualize, which is super important for a lot of people because of distance and geography and timing and money. But to scale that, we also need to automate it. So those are the passions that I bring, because if we do that right, we don't really have a shortage of physicians in this country. We just have a shortage of using them efficiently. And by bringing together the ability to virtualize a visit, to automate as much as possible, particularly the routine, repeatable activities of the visit, we can really start to think about scaling, and we can let doctors in the office focus on more time on the patients who really need it, and less time on the folks who just have a routine, repeatable issue.
Fascinating. So my first observation here, Dr. Berkowitz, and actually Dr. Zelis too, is there may be a genetic link. So the next time we do this, we're going to get your genome analyzed. It was clearly children of doctors and both in telemedicine. So there's something interesting there. The first tweetable moment, I think, for today is the tyranny of the office visit, and how that resonates to so many people, from caregivers to moms and patients as well as clinicians. So I think those are some very interesting insights. So let's go over sort of broadly what we want to do today. We're going to bucket things into basically 5 key areas. We certainly want to look at some of the strategies around where telemedicine is today and where it's going and how we can implement it. Secondly, we want to look at the culture and the culture of change. I believe that this is very, very important because change sometimes comes from the outside in, but also from the inside out. I think Dr. Zelis' experience at UH will be some great insights around there. How do we engage providers? How do we get them part of the process? Is it competition? Is it co-opetition? Is it an extension of primary care in a more linear kind of fashion? Also, the efficiency of care and scalability is something we will look at. And then, of course, we'll take a look at some of the challenges. Certainly, telemedicine has been around for a while, but I think today's opportunity to dig a little deeper and identify some of the challenges that might be perhaps holding us back or points of challenge or difficulty. So I want to start with the hardest question and the simplest question first, because this is something that's always bothered me a little bit. And that's, what is it? Is it digital health? Is it telemedicine? Is it virtual care? So Dr. Zelis, I want to see, number one, your gut. When you refer to this methodology, how do you refer to it? And then let's look a little bit broader at some of the other terms that are in the domain.
Sure. And I think, we liken this on aspects of, I don't know if the consumer, the healthcare providers, and even some of the disruptors outside of healthcare and the vendor space, I think we're all trying to dabble to determine what's the right name at the end of the day. When I think about it in a component, very much like Dr. Berkowitz said, telemedicine is, delivering medicine and medical care, on electronic platforms. And as you mentioned, we've done this across the telephone for years and years, but now it becomes a whole different platform when we think specifically just about telemedicine on aspects of virtual and face-to-face. As you expand, and digital health and virtual care seem to be a little bit broader, this is when very much you're starting to incorporate aspects of how do we incorporate those artificial intelligence and those predictive analytics to really reach some components of higher level of personalization, levels of automation that allow for aspects of efficiencies. So it does become the really component. I anticipate most of this broadcast would be focusing on the telemedicine, but you could have, an hour plus and probably a full day seminar on each of these 3 pillars, let alone this question.
You're right. As a Twitter guy, we often try to get it down to the simplest of words. I've found that telemedicine, just like the Patriot Act and death tax, there's sort of psychopathology around these terms. And, Dr. Berkowitz, your take on this. I mean, throughout history, has it always been around telemedicine, telecare?
So, yeah, people definitely get caught up in terms. And, we probably don't, I think the most standardized term at this point is telehealth or telemedicine. Some people differentiate. I don't get as caught up in it. But I think while that is the term that's being used particularly at federal and state regulatory level, so we can't ignore it. And while we have often used the term, e-care, virtual care, etc., the more we think, we think about this every day. We talk about internally, and we're really moving to more of a concept of online care. In the same way that banking is not virtual banking. It's not telebanking, it's online banking. It's just taking the extension. I think when something new comes along, you really have to set it separate, but over time, it just sort of starts melding in. And really so much of what we do, particularly in the outpatient arena, is online care and doing, taking care of many of the same things, but also starting to realize we can do a lot more. When we talk about being able to be available 24/7 within 10 minutes, remote patient monitoring, using, a variety of automation techniques. It is becoming more similar to how we work with our bank. Yeah, and one of the analogies, a couple of analogies used are, when you need to get $20 from your bank, you used to have to go in and talk to someone at the bank, and then they had tellers, and then the ATM at the bank, and now you can transfer anything you want online and send money back and forth fairly easily and find that ATM almost anywhere 24/7. Same thing when you go online shopping. You're not just simply doing a video with some shopkeeper somewhere, right? You're automating and providing a lot of self-service, but you always have the promise of being able to talk to someone if needed. And these, in every industry, have evolved. In the late 90s, early 2000s, we used to use a term for them, virtual and e-commerce, etc. But really, it's just become online. So I think we're going to see the same transition happen with healthcare. And as people become aware of it, it's just going to be a natural part of what they do. I can get care in the office. I can do it online. I can do it on my phone. And it will become less of a distinction in terms of terminology, as much as I can get care anywhere.
I would imagine that, like so many aspects of technology and innovation, telemedicine will emerge to become just medicine, where that front end really just goes away. Dr. Zelis, I want to talk about sort of the future and the past, and look at how UH and MDLIVE see how strategy has evolved. And I want to look at it from sort of three general areas. One, I'd like to get a sense of technology, about how technology has empowered clinicians and patients, and then from the side of the patient and also the clinician. So how has things changed over the past, let's say, 5 or 10 years?
I think what the previous question really helped, because we do need to think about this as just another way to deliver health care. It's not going to change the type of treatment that would be done in person for let's call it a basic urine infection or even some other aspects. It's going to heighten the ability to be efficient in just another method. So I want to lead on that. In the 3 pillars you discussed, the technology, patient, and clinician. Technology is the velocity by which technology is improving is so fast, and healthcare at the end of the day, our adoption of technology has been, I would say, slower. And so this is where we need to embrace, and one of the great things of partnering with MDLIVE, but also with other areas, is embrace the expertise of technology developed with health systems. And together, we'll be able to synergize for both the improvement of strategy to offer these more efficient cares. For the patient, the world is now the world of consumerisms for healthcare. High deductible plans that are offered in Ohio at over 90% of all our employers. Consumers have the choice and are expecting the choice to get healthcare the way that they want it, with their own dollars, with high deductible plans. So it's really important that we meet the consumer so that they can make their choice of where they want to spend their healthcare dollars. And for clinicians, going back on aspects from the regulatory components and aspects of the increased requirements of quality, we need to embrace the aspects that delivering healthcare is changing. I believe it will be a hybrid approach. Many people, just like going back to the bank example, there are still people who like to go into the teller. There are still people that like to have that face-to-face interaction. So there's going to be a balance, but we do anticipate, if you think about it from the banking, there are some simpler transactions that may or may not require as great of a time investment and can leverage aspects of technology. But something that is different about healthcare is the value of relationship, and also the component also of that aspects of health that sometimes are very difficult to quantify, those personal interactions, the knowing across the continuum. So I look forward to seeing how we can merge both the qualitative and the quantitative aspects in telemedicine. That's where we'll hit the sweet spot beyond just data mineable components, but that other component, that qualitative part that really helps make medicine an art as well as a science.
So I'm gonna, before I flip it over to Dr. Berkowitz, I'm gonna give you another tough question, Dr. Zelis, and I want like a one-word answer, if I dare. Who is more difficult a sell in the telemedicine dynamic, the patient or the physician?
So I'm going to rally it back to you and say I'm going to give you option 3, which is the consumer. Because the consumer at the end of the day is both the patient as well as the provider, because it's not really most about the sell of it, and we're going to transform whether we like it or not, or both sides. Who's leading the adoption of telemedicine better? Most likely the patients. But that's where I would start there.
Good. No, I think that's an important dynamic. You know, we talk about things like Eric Topol's book, The Patient Will See You Now, and consumer centricity. I think these are important aspects. So Dr. Berkowitz, let's start with that last question first. Who's leading the charge? Who's more recalcitrant or difficult? The patient, the user, or the clinician? And then we'll go more broadly around where things have changed over time.
Yeah. So in terms of who's most resistant, I strongly say the provider at this point. Who's leading the charge, that's more difficult, and that's at the system level, right? Because remember, when we say provider, we're talking about the health system. So you have someone like Dr. Zelis at the system level, thinking proactively, thinking about the future, gets it, right? Gets the consumer wants it. But then at the low level, you've got the providers who are scared. You know, they're like wondering, are you stealing our patients? Will I lose a relationship? Will I lose money? You know, what's the quality of this? You know, if I'm not doing it, and who has time to do all of this? So I say this because our statistics show when patients become aware of the service, you know, whether it's a direct-to-consumer patient, whether it's, you know, through university hospitals, the patients are awed by it. I've seen it. I take consults on the system. My doctors on the system tell us, like, patients are like, this is like science fiction. I can't believe I'm at home, my bed, on my couch, talking to a doctor who can actually help me and come up with a plan. This just saved me 2+ hours of time. It's, you know, which is, time is money these days. I don't have to wait a couple days to get in. And, you know, I've got someone who knows what they're doing. Once they use it once, you know, they on average are using it almost 2 times a year. What we find is the biggest issue is awareness. And once patients know about it, they think it's amazing and they want to keep coming back. So the key is, how do you get doctors not simply to accept that this is happening? Because if you look at so much tele-urgent care, it is, you know, it's being done by a variety of different places, but less and less is done in the primary care office. But you need doctors to embrace this as a primary care doctor, to say, I'm not just losing someone, but this is now part of my team, this telehealth team, whether it's, you know, my partners and whether it's me, my partners are doctors, or some other partners, that now they need to feel the quality is great. They need to feel the relationship is upheld, that they get all the information. You know, you need to think about, you know, financially, how do they benefit in some ways? You know, whether that is because now they can see patients who, you know, need to come in who might have more complexity and higher RVUs. They have room for new patients. Maybe they're even reimbursed to follow what happened to the patient virtually. But yeah, I would say the patients want this, but most of them don't even know it exists. So the people who are leading it are the large healthcare system providers and folks like Dr. Zelis who get it, but they've got to pull along the doctors and make sure they feel comfortable with it, while making sure the patients are even aware of this on a day-to-day basis. Yeah, that becomes as said earlier, just a part of routine care when they call in. Hey, how would you like to be taken care of today? Do you want to come into the office? Do you want an online visit? What's the easiest thing for you?
Let's unpack that a little bit and move on to the next question, because I think they segue very nicely. Dr. Berkowitz, you articulated the notion of wow very nicely, and I would echo that sentiment, that I think that once patients experience the quality and convenience of telemedicine, that it becomes a real aha moment. So it's good to know that that reality exists, and in fact, once it's the try it, you like it kind of dynamic. Dr. Zelis, I want to talk about the culture of virtual care. Right now, my sense is that virtual care is, to a degree, an outlier in the sense that it's not part of the continuum of care as it potentially could be. We can go both obstacles and opportunities here. But in your direct experience, in the real world, I'd like you to comment on this a little bit.
Sure. I think many of us all know at the end of the time that, culture is a marathon and it's a journey. And so, very aspects of some basics of, change management will lead to cultural change. So some of the key areas that we've had at the end of the day on aspects that you need your leadership aligned, that this is a key initiative. You need to create that sense of urgency on aspects of this is a demand external to us, and so that there are both internal and external urgencies on why we should continue to move telehealth forward. You need to align aspects of incentives so that people are not concerned that their business will be business as they understand. It will change, but the components, whether it be their productivity or their patient care, are unchanged. And finally, at the end of the day, you need to not build it. You may have separate wins on aspects of individual programs, but it needs to be have standardized aspects where it's incorporated into normal workflow. So while technologies are learning to integrate, it needs to, we get short-term wins on aspects of, MDLIVE being our virtual visit provider and virtual on demand. Again, partnering with them on how they can be also the virtual office, so that when we offer an appointment with our patients, it can be, oh, you need to be seen for a sore throat. Would you like to come in? Or be seen, virtually, right? That it's a seamless experience for both the provider and the patient. As you get those individual wins, but build on a foundation of system change, that's when you start to change culture. And so, you can't go, you will change culture as you get the wins. So those are some of the things that we've done on aspects to really start thinking that, a virtual or telemedicine culture is where we're going in the future and where we need to be now.
Dr. Berkowitz, I want you to follow up on that a little bit. I know that there has been some issues around just general obstacles, both internal and external, to the adoption of telemedicine. Any insights on how we can get around that?
Well, I think Dr. Zelis is so on with the culture and getting a health system to truly understand, believe that this is, the natural evolution, and to buy in and to understand, right, that this is happening. And from a health system's perspective, this is their blockbuster moment. They're sitting there and they have to.
If I can jump in real quickly.
Yeah.
We talk about the natural evolution of change. And for me, I've studied this and I've talked about the notion of punctuated equilibrium, that we know that in evolution, nothing happens until something pivotal happens and then there's change. So I don't know if the adoption of telemedicine is as linear as sometimes we talk about it. What are the inflection points? What are some of the areas where maybe, let's say, the institution of the smartphone, of a video-enabled smartphone might have been one of those things. Are there other points, Dr. Berkowitz, and then I'm going to come back to you, Dr. Zelis, about this. What are the inflection points or the things or the critical mass that we should look to?
Yeah, I think probably the biggest one that we look at is the sponsorship of these systems. And let me tell you what that means. When MDLIVE was started 10 years ago with a number of other telehealth companies, the idea was it would be direct to consumer. Consumers would just jump and do it because it was convenient. And over the years, that still hasn't fully realized the potential because unlike a lot of other industries, there is something about healthcare where you want to have some comfort level in knowing there's legitimacy to who you're talking to, et cetera. And what we found over the years is that large health plans, large employers have found offering telehealth is something that is effective for their patients in that, one, they get a clear ROI. They see we've had studies showing a total decrease in cost of almost 20%, borne mainly by decreased ER admissions by over a third. Like that's hugely important for them. And it's great for the patient. And most recent stats show well over 80–90% of employers have or are planning to make sure telehealth services are offered to their patients. So we're seeing across the nation that more and more patients are having telehealth as a part of their package, their healthcare package. But they're also looking to their health system to say, how can this be offered? And so we're finding that one pivot point is going to be patients, members starting to recognize that this service exists, and they're looking for who they should work with. Should it be their health plans and employers? Should it be their health system? I think the answer will be a combination. But right now, the employers and plans are ahead of the game, and health systems, again, I said they're blockbuster moment. This is their time to rise up and say, am I just going to want to be a single office setting where everyone has to come to me? It's all about the provider. Or am I going to switch over and recognize that patients are looking for care and they're looking for more convenient care? Not necessarily for the super complex stuff, but certainly for a lot of primary care, which is routine care. And if they don't offer it, someone else will. Dr. Zelis and university hospitals are recognizing that that's important and that there's a lot to do there, and that partnering with MDLIVE gives them a variety of scalability, both at the technology and automation level, as well as overflow if their doctors aren't available. And that puts them in control of the situation.
I think that in echoing back some of your points, just knowing that the service exists is clearly important. But there seemed to be a fair amount of data with respect to cost. You had mentioned ER admissions. So, these are important areas that I think are emerging as inflection points. Dr. Zelis, can you, in your experience, do you parallel that thinking? Maybe some new insights from your worldview.
Yeah. As I think about this, it almost goes back to, if you remember the question you asked on aspects of strategy, the three aspects of strategy: technology, provider, and consumer. And I think each one of them has to have an inflection point by which they merge together. So, for example, I would say from the technology point, I think we have a lot of technology that is, while there is a single platform like you referenced, like a smartphone, but technology and aspects of software and stuff, and what are we trying to do? There are many people in those spaces. So I don't think everyone's gotten the complete piece de resistance of really being able to do it as seamlessly as the evolution has been in online banking. So technology, while growing exponentially, is still in the discovery of, there's some levels of still doing, how do we actually all do this? The second, I would say, on aspects of the provider area, really pivots on that inflection point of when there will be a change on both volume and value-based payment, as well as the legal component. So when two aspects when it comes to payment. When there becomes healthcare reimbursement parity across whether it's an in-person or a virtual visit, that will be critical to allow it easier. And then the second, when payment for providers and health systems, whether independent affiliated, transition to value-based, right? Where I'm paid, as we are starting to go there on aspects of, risk-based contracts and bundled, when I can do it more efficiently, and that kind of, widens the profitability component. And then third, the consumer component on aspects of the inflection point there, probably, as you mentioned, starts going back on their own demand and their own knowledge. So what I see is where it's not a single technology inflection point. There's three separate inflection points that once they cross, that's when the velocity of growth of telemedicine will really rise.
Dr. Zelis, I want to stay on your last point regarding the consumer and take a look at our next question. And the term for me, which I think is quite resonant, is the notion of virtual first. In my experience with my family, my wife and kids, I sense that telemedicine is often seen as a tool of last resort, that it's in the middle of the night, my doctor's closed, I don't want to go to the Mediclinic or the emergency room, and that it becomes a virtual last. I'd like you to kind of comment on that and discuss things from acuity to how really your first line of defense might be that wow visit, as Dr. Berkowitz alludes to.
I think this goes back on aspects of virtual first. This becomes a component of understanding the scope and the scalability of what's able to do. Going back again to the banking industry or the Amazon industry, the first time, you tried something, it was different and we weren't sure. And this does become some level, I think we find the adoption of telemedicine occurring more of a virtual first in perhaps some of those who are earlier adopters, whether that be a millennial, whether that be more of a digital savvy. That at the end of the day, they will become the consumer advocates. And I think we'll see that again on both sides of the spectrum, both the consumers, those who adopt the virtual first aspects, and those, again, just like probably we saw in banking and shopping and all those other areas online, we're going to have those digital savvy people who will lead the virtual first for healthcare. Likewise, same on the provider. We have our own here at UH. We have a core group of providers who are our virtual champions, who see this, they see the big picture and know that this is where we're going. This is where, again, you have those short wins, those small wins. You celebrate success and you launch and you show metrics of success of patient experience. You show metrics of lower cost. You show equal to, or if not better, aspects of quality. And when you get those components moving things forward, that's when you start doing the virtual first culture.
I want to push on to the next question in the interest of time here, and let's stay with you, Dr. Zelis, and then we'll go over to Dr. Berkowitz for some insights. Certification training, I think, is important because one of the questions that come up quite regularly is the quality of the care on telemedicine. Can you help us understand how you manage that, and what are some of the advantages and pitfalls for our audience?
I think that's the biggest question, and this is on both sides, is can I get the same highest quality care? And both providers as well as patients wonder on aspects of the quality of care. And we do see that both internally as well as with our partnership. We do assessment on some of those core metrics of qualities. What we have to understand, again, and this goes back, is that telemedicine is about a method by which to deliver the medicine by which we were trained in general. So it is more on aspects of, are you asking the right questions to get to the information? Are you using perhaps innovative ways by which to examine a patient or discuss to gather the information? I'll remember back in medical school, usually at the end of the day, I think the quotes were anywhere from 80 to 90% of your diagnosis is made with just listening, right? Now, listening does involve more than just listening with your ears. It is listening across on aspects of seeing facial expressions, as well as sometimes even external environments when you have a virtual face-to-face over the components to understand some of the complexities of a patient's environment. So this again goes back to the qualitative and quantitative components of a patient's interaction. So I do believe this is part we've actually aligned a internal certification training here that does on aspects lead to our own UH values that we ask. We have we have hundreds of our providers here at UH. While we're 2,000 employed network, over 300 of them actually have telehealth privileges in and of itself. So that's really important that we align their training. So we're working on and have rolled out a certification training process to make sure that the practice of telemedicine, what method by which we deliver virtual care is consistent along our UH standards.
Dr. Zelis, I want to understand a little bit about, is it UH patients using UH telemedicine, and is that intrinsic connectivity a comfort zone for patients? And then we're going to go over to MDLIVE, which I think is a little bit more disconnected in a sense.
Sure. We're reaching to both audience, right? Both our established patients, which I think are the opportunity to engage provider and consumers on aspects of establishing that next relationship. So one of our virtual programs that we have is our gynecologist oncologist survivorship program, where again, to the efficiencies and the ability of a well-established relationship, we can have that encounter, virtually over a face-to-face interaction electronically. There's an established relationship, and we can break through some of those barriers. However, we have very successful, both through MDLIVE and our virtual on-demand, as well as a very successful multi-specialty outpatient virtual clinic, where our academic providers connect with community patients who they have not yet met in the past for specialty care such as neurology, neurosurgery, hepatology. So we are looking to both I would say our established patients, our new to service patients, as well as our direct to consumer to help build UH alignment across our community.
Dr. Berkowitz, tell us a little bit about certification and training and really optimizing the clinical experience on telemedicine with your staff.
Yeah. So first of all, and Dr. Zelis mentioned this a little, is we're starting to see sort of this new specialty form, this concept of a virtualist. Similar to the rise of the hospitalist in the 1990s. It sort of started out organically. Folks were drawn to it, but we're starting to get better at training, certifying, etc. So in our case, we do a couple of things to allow doctors to be on our extended network. We have over 1,200 providers. Each of them have to go through an extensive credentialing process that reviews their history, their experience, etc. And after that, they go through a multi-hour training process to get them on board. And this, of course, is also after interviews with our staff, etc. So once they're on board, we actually follow a variety of metrics on them and report out to them on a regular basis. That includes everything from the length of the call, certain HEDIS metrics, their patient satisfaction scores, and we do random chart audits on an annual basis, as well as more intensive chart audits if they're not meeting any criteria for some reason. And many of our doctors, are doing this on a regular, consistent basis and becoming very good at website manner, as they call it, and becoming virtualists. There's not a formal national certification per se, but again, from our perspective, involves finding the right doctors to start with, training them well, keeping them up to date. We have monthly webinars to review things with them. We have a series of physician provider ambassadors who do outreach to them, as well as are available for any calls, and the constant monitoring, and we're getting better and better. And I will say something that stands out with what we do, which is a bit unique. And when I came in, I was pleasantly surprised and happy that we actually record every call, audio recording. So when there is an issue or we need to do audits, we don't simply look at the notes, we listen to the recording. And we have a standardized way to measure both the quality of the service as well as the quality of the clinical part of the visit. And it's incredibly helpful to be able to do that on a consistent basis. And we're now starting to explore a variety of natural language processing of the text and machine learning to understand, and we can predict ahead of time based on doing over 1 million visits. When visits are going well, when we may have to prompt the doctor about something special to be aware of, and as well as doing a retroactive analysis of all of our visits. So
I want to jump in a little bit. I'm going to take a look at some of the questions. There are a lot of questions coming in, and we still have a few more areas to go through. But the next slide, I think, touches upon not only an important aspect of our discussion today, but also what I'm seeing in the questions. There are many questions regarding engagement strategies. How can I get my clinician to embrace telemedicine, or how can I get my patients to use it as appropriate? So Dr. Zelis, I want to try to keep these next series of questions fairly short, but are there any home runs or any success stories that you can share with our audience to help them drive their business and engagement?
Sure. I'd like to comment just one quickly though before those tactics that we have used that have shown success. I think I agree that telemedicine, that virtuals will become a certification at some point in time. What I think at the end of the day is people will still have a core specialty, family medicine, internal medicine, and one of the components at the end of the day is that balance of providers who are always virtualists versus incorporating that everyone has the ability to provide virtual care. And so this becomes the evolution of how does the specialty of telemedicine evolve. That's leading on what, building on what Dr. Berkowitz said, and that leads into the provider engagement. At UH, some of the areas where we have had success is, number one, we have a significant physician advisory committee, which are our key champions who have led multiple aspects of these programs, from our virtual inpatient, outpatient, on demand, having that core group of providers who can help be the voice. The second is we have actually worked on aspects of a provider incentive and program based on aspects where we remove aspects of financial risks when it comes to certain areas of engagement and incorporation, as well as financial benefits for some of our providers to take that risk. Third, the other area that has been extremely successful in adoption has been that key area of communication, because incentives aren't necessarily all financial, that aspects of acknowledgement and communication for what we've seen as our senior leaders have acknowledged providers for doing innovative and new ways of delivering care. We will be most likely launching a virtual health program of the year where, again, we can highlight it. So very simplistically, one, a core group of advisors, a group of your champions that are peers to help advance this. Two, individual provider incentives alignment. And three, verbal recognition of successes that occur in the telemedicine space.
Dr. Zelis, I want to sort of combine the next two concepts a little bit regarding improving efficiency in a healthcare system, but also helping patients navigate access through a healthcare system. I believe what I'm hearing is that we have a visit, a otitis media, a high acuity, but it seems to me there's a richness of telemedicine around comprehensive care that may be an emerging area that's critically important. Can you comment on that, please?
So these three areas that are outlined here when it comes to quality, access, and efficiency, I mean, all three of us are doing all three of those areas are so many areas that we focus on when it comes to aspects of, cost control and improvement across all the different projects in a health system. So telemedicine needs to be seen and can deliver on each three of these areas. I think we're still working on the process improvement on how in each different model it's incorporated to be more efficient in quality and access. How is the technology integrated in a seamless fashion? Access, how is it already incorporated in your scheduling system? How are we measuring quality? So you're absolutely right, this question that health systems, we do look at how telemedicine will improve these three things, but we need to, go through those lean processes to show how to actually work them through the process themselves.
Dr. Berkowitz, help me understand a little bit about the broader context of telemedicine today. I know specifically MDLIVE is looking at things like dermatology and mental health as components to a richer offering for both the consumer and the clinician.
Yeah, when we think about primary care, it involves, certainly, what the classic, pediatrics, family physician, internal medicine. It involves urgent care, chronic care, preventive care, but the bigger umbrella, certainly a lot of, when we set up primary care at Northwestern, we also looked at, what is common, dermatology, behavioral health. These things are really common and should be part of the primary care that's delivered at MDLIVE. We built up a network of therapists and psychiatrists who can help in a variety of ways for that initial online care. Dermatology as well. These are just routine things people have lots of questions on. What we need to continue to do a better job of is making that more and more working in a synchronous manner, so that a doctor a primary care doctor can bring in a therapist or psychiatrist to help in a variety of ways, help with a patient who's undergoing certain issues. Again, today we focused on urgent care, but over time we'll be able to support a variety of other things. And again, I wouldn't look at it as urgent care versus chronic care versus preventive care as much as which parts are routine and which things can and should be done online. And in some cases, which you talked about quality before, Dr. Zelis mentioned a variety, and we talked about certification. And quality means, as I said earlier, not simply following certain evidence-based medicine guidelines. That's important. Quality also means experience, but quality also means access. And again, in a large health system, all the patients who come in and see you, but there's a percentage of them who will only come in during emergency, and then there's a percent of them who just won't even come in. And being able to offer them online care, the idea is not that it's a lesser care in terms of what you can do online, as much as it's their first lifeline. It is that primary care first, and whether they come in through an urgent care setting, a behavioral health, dermatology, it's helping them reach out to the things that they need that are important to them, that then gets them to culturally say, hey, I can do more and more of my care online, but I always had the promise of being able to go in if needed. For any of these situations, you want to have that link so that when you really need to get in, you can get in, and access, in a sense, cuts both ways in those situations for any of those specialties, meaning you have easy access online, but also because of that, because the routine things are not clogging up the doctor's office in the brick and mortar setting, you have easier access to get in when you need for the more complex issues.
Dr. Berkowitz, I want, and I'm going to give you 1 minute on this, and I know this is an hour question, but could you tell us the status of reimbursement and the regulatory environment around telemedicine? And then I'm going to wrap it up with a few futuristic questions.
Yeah, I think we're seeing at the federal level, things are moving quickly. Dr. Zelis mentioned earlier, one of the key pivot points will be financial reimbursement. We're seeing the federal regulations moving more and more towards telehealth, meaning, for example, Medicare ACOs, it's becoming easier for them to pay for and reimburse for telehealth, and a variety of other laws and regulations at the federal level, really leaning towards making it easier to charge for and do telehealth. Although, there's still questions as to exactly what we'll get paid for. Things are moving. At the state level, it's a little more difficult. We still have, obviously, licensure issues. Every one of our doctors needs to be licensed in the state in which they're taking care of. It's actually, legally, if someone calls from the state of Ohio, Illinois, Michigan, we need to have a doctor who's licensed in that state. So we have doctors who are licensed in multiple states to take care of that. And I think the states also, have, interestingly, sometimes very high barriers. They require, certain things, video only versus whether it can be done with a phone call. In a state where rural patients don't have good access to video level bandwidth, that's a shame that that's happening. We're starting to see that slowly change, but
good.
Federal government's certainly moving more quickly.
Good. Dr. Zelis, I want you to put on your futurist hat for the 2 minutes that we have and tell us your vision of telemedicine 2.0, or dare I say, telemedicine 3.0. And I want to echo back to a question which I think is very interesting in light of the Apple Watch and consumers detecting atrial fibrillation. What are some of the things in the future that you see? And could you also comment on the role of wearables as devices that can augment the telemedicine visit and care in general?
Sure. It's certainly an exciting time. I think we need to imagine beyond what we ever thought was imaginable in the past, in the future. And, when you think about it going, where could it be? And really, that's an actual fun design session of think the impossible and it can be there. From a, putting my provider hat on, the health systems hat on, telemedicine itself will continue allowed to get us back to the ability to do no harm and continue to have the highest reliable medicine, the highest patient quality care, and back to what we wanted to be able to do. So as we think about things like wearable that will provide data to me and our patients for us to really be partners to predict. In long term, what we'll be able to do is be able to lengthen life expectancy, improve people's quality of life and, their compliance with medications, actually improve aspects of people's wellness rather than treating them always when they're sick and episodically, but to be a real partnership of why I went into medicine as a primary care provider, to really take care of the whole person, body, mind, and soul. And to me, it's kind of like I think about technology as being the adjunct to really be able to provide that fourth dimension to really take care of things. So while it was body, mind, and spirit, how can I add technology to enhance that component to really take care of a full patient?
That's fascinating. Body, mind, and spirit, and an element of technology to provide that fourth dimension. That's a fascinating concept. Our time is up, and I would like to thank our audience for their engagement and participation. There were a lot of questions. I tried to weave them into our dialogue, but on behalf of Dr. Lyle Berkowitz and Dr. Cynthia Zelis and our sponsor, MDLIVE, thank you for participating in today's conference. We are truly at an inflection point in human history. And one of the avenues we're traversing is telemedicine, and it will play an important role in health and wellness. Thank you all very much.